Hello, I'm Dr. Caroline West. I'm a GP and I'm here today to talk to Dr. Bethan Richards, who's become the Chief Wellness Officer here at Royal Prince Alfred Hospital. And she's piloting a new, very exciting program called MDOK, and I'm here to find out today what their experience has been so far and what perhaps we could all learn in terms of strategies to help us prevent burnout and to improve our wellbeing. Hi Bethan, thanks for being with us. So how important is wellbeing for doctors?
Doctor wellbeing is so important, I think, because the lack of it is having a really major impact on our healthcare system. We have one of the best healthcare systems in the world, arguably. But at the moment, I think the healthcare system's under extreme pressure and we're facing our own epidemic, our own crisis. And that crisis is doctor burnout. So what we know with doctor burnout is that it's got a huge impact both on the individual and on the organisation at large. And actually at the end of the day, that'll affect patient care. So it's got a huge effect on our community. In terms of, why is this happening? There's a whole lot of levers that are driving doctor burnout. The impact on the individual is enormous. We know that people that are suffering burnout have higher levels of anxiety, higher levels of depression, higher levels of relationship breakdown, and also tragically we're seeing more and more suicides out there. In terms of the organisational level, what we're seeing is a loss of doctors to the medical workforce. There's a huge investment that goes into producing doctors and there's a huge need in terms of access to care, and losing doctors to the workforce is a really big issue in that regard. We also see higher workers' compensation claims. We see increases in sick leave. So there's a real cost of this to our society and to the healthcare system. Importantly, probably one of the most important impacts of burnout is also on patient care. So we know that for every increase in burnout point, we're seeing an increase in medical error rates. And that means harm to patients, it means a reduced quality of care. And I think what we're seeing is reduced time for care and reduced compassionate care, which is really what the community needs. So it's a really huge impact on our healthcare system and needs to be addressed.
That's incredible to think that there's such a big epidemic of burnout.
If you look at the health system in general and the levers, I guess, we are under extreme pressure in terms of the numbers of people we're treating, the complexity of care that we're trying to deliver. I think the demands of the community on us have changed over time. I think the impact of the fear of making an error and working in a medico-legal sort of driven environment. I think the internal drivers that we all have of a belief that we can save or cure everyone, that we can get it right and perfect every single time. I think with the huge number of doctors coming through at the moment and the lack of training positions and the lack of specialty or other positions at the end of the day, there's a huge competition coming through. And so not only now are doctors doing their day jobs, but they're also doing master's degrees on the side or PhDs, or trying to buff their CVs by doing research projects just to get onto training programs. And even if they get onto those training programs and work the grueling hours that are sort of expected these days, there's not always that job at the end of the day that they've been working towards. And so with that lack of sort of hope or light at the end of the tunnel, I think that's really fueling some of the burnout.
So how would somebody recognise when they have burnout? What sort of symptoms would they get?
One of the problems we see with people that have burnout is that they do not recognise the early symptoms, and in fact it's not until it's very late into the course of the problem that they're realising that there's an issue and that they're in significant trouble at that point.
So a lot of doctors and allied health professionals won't even recognise that they've got burnout.
I think if you look at the definition of burnout, burnout's defined by three different categories. The first one's emotional exhaustion, the second one's depersonalisation or cynicism, and the third one's a lack of personal accomplishment. And when you go and look at the doctor audience, what you see usually is a decrease or a problem area in the first two. So we find that they identify early with emotional exhaustion and depersonalization. And that actually happens quite early on in training. Now, people feel exhausted and can feel detached or depersonalized at times, but they take a break, they get away from work, they have a holiday, they participate in wellbeing activities, and they recover. What you see with burnout is this insidious sort of onset of an exhaustion that does not recover, and of a depersonalization that does not get better, and you get a real negativity, I guess, that comes along. Interestingly, most doctors will increase their work rate to cope, and so they maintain their productivity. And they'll often throw themselves to work harder, which to maintain that productivity, which actually makes the problem worse. And so at the end of the day, what sort of symptoms and things will you see in people? You'll see a change if you're looking at your colleagues. They'll look tireder. They may complain or be more irritable about things. They may just not be at events that you'd usually expect them. So they might not just be around much. I always used to worry about the trainees I'd look after that used to fly under the radar a little bit or would suddenly not be very visible. You'll see people that have more interpersonal conflict or are more sensitive to things, and some people may react by presenting as a bit more angry in ways, and some people will do the opposite and go into hiding and be quiet in ways. So everyone will be a little bit different, and so symptoms, I guess, the best thing to look out for is a change in behaviour in that regard. And
can you take me through what you're doing here in terms of your pilot program with MDOK?
We're using the Stanford Model. So the Stanford Model of addressing doctor wellbeing says you have to look at three key areas. The easiest area to look at first is to look at the individual level and how we can make our frontline staff feel heard, feel supported, and give them new skills and knowledge that better empower them to look after their own wellbeing, not only just during their training, but actually ideally for the rest of their careers. The second component is then to look at the system processes that are contributing or influencing doctor wellbeing. And the third process is to look at the culture that we're working in, and particularly medical culture, but also our organisational culture. And so what we've tried to do with our program is address all those three areas. To do that, we had to start and put a platform in place, and we had to start a conversation. Was not an easy one to do. Mental health disorders are obviously stigmatised, and probably most heavily so, ironically, in the medical profession.
So having cultural change is really important too.
I guess the first key barrier that we faced was a real perception and a almost lashback from the junior medical staff to say, don't fix me, fix the system. I'm resilient, don't give me resiliency training, fix the system which is breaking me. And so we had to sort of step back from that conversation and look at the fact that we're not trying to fix anyone. In fact, what we should be doing from medical school onwards, and actually probably earlier, is preparing people with the appropriate skills and training for the environment that they're about to be practicing in. And whether, we have arguably one of the best jobs in the world, but it is an incredibly difficult job on an emotional level, on a physical level, with the hours and things that we practice, and at the end of the day, just on a giving level, and being there every day, often with people who are having the worst day of their lives. So to adequately prepare people for that, I think needs a slightly different skill set and knowledge that we're not necessarily training people for in medical school. And so by doing this and giving them these new skills and knowledge, I think we're not only going to improve their capacity to operate in the environment that we have right now, but we're actually going to improve the quality of the doctors that we're producing, because people that have these skills are going to be able to better manage patients. They're going to see the suffering in their patients better, and they're going to be able to better offer strategies for how to manage it because they've either done it for themselves or their colleagues along the way. And this is a lot of things that aren't currently being taught in medicine.
What are the different areas of the program that you'll be exploring with the doctors here and the staff here?
I think the first thing in the first workshop we often run is a goal setting and a work-life balance workshop. So what that does is sort of two things. In a junior doctor or a broader GP audience out there, that workshop focuses on getting you to step back and think about what the most important things in your life are, and then think about how much time you actually spend on those things. And sometimes that's a very confronting thing for people to do when they're spending 99% of their time at work and letting everything else in life go by the way until they've reached that magic goal of getting that exam or getting that research paper or whatever it is that they're driving towards. The second thing that it does is it teaches you about how to achieve things, not only for yourself, but again, translating that into patient care. So we teach people how to schedule things and actually achieve the goals that they set themselves.
Can you take me through the program and tell us a bit more about it?
Sometimes the simple things are underrated, and in terms of what we know for wellbeing, the two most powerful intervention strategies you can do are to build social connection and to exercise. So one of the things we've tried to do in the program is combine those two things together. So if you can find any group reason to exercise, you can actually have an incredibly good wellbeing activity, let alone if you can make it fun and have some humour as well.
What sort of recommendations would you have for GPs out there who may be feeling as though they're struggling?
This is an incredibly common thing to be feeling, and actually a normal thing given the work that we do. So I think the first key message is anyone feeling in any way like things are getting on top of them is that you have to talk about it. And that may be with a friend or colleague. It may be with a professional. And I guess at the beginning it's who you feel comfortable with talking to. But do not internalize it, do not ignore it, try and talk to someone. I guess the second thing in terms of people in that sort of early state is what sort of things, if you can do one or two things to address it that are really simple and in your control, what would you do? I think some sort of social connection, talk to a friend if you're far away, it could be phone, it could be Skype, some form of get out of the house or get moving, and bring some form of nature or exercise into that equation. And it doesn't mean having to go to a gym. It might be get outside and go for a 10 or 15 minute walk just to sort of change that mindset. If things aren't getting better and you try some of these sort of early strategies, the great thing is that firstly you recognise it, and then the second thing is to do something about it and to realise that that you are not alone, and that going and getting help for these problems is absolutely the right thing to do, and it's almost the courageous thing to do.